Welcome to the Deflux for VUR YouTube channel. I'm Carrie Redd, Training and Education Lead for Palate Life Sciences. Today, we're joined by my friend, Hal Scherz. So Dr. Scherz, we've been talking about children with urinary tract infections and then the suspicion that multiple UTIs and febrile UTIs could point to the fact that the child may have vesicoureteral reflux. So if this is a suspicion, how is the diagnosis made for these children?
Well, Carrie, thank you for having me again on the Deflux station, and I'm delighted to be able to speak to parents across America about this topic again. When we see children who have urinary tract infections, especially with fever, that's reflux until proven otherwise. And the only way that we can make that diagnosis is with a study radiographically to determine whether or not reflux is present. There are several newer approaches, but the historical way of making that diagnosis is with a study involving in the introduction of contrast into the bladder through a catheter, and then they take pictures as the contrast is introduced into the bladder, and then the catheter is removed, and they continue to take pictures as the child urinates. That study is called avoiding cystourethrogram, and that is the gold standard in making the diagnosis of reflux. There are some other ways that have been used to diagnose or follow children with reflux using nuclear medicine studies, and more recently using special ultrasound techniques. But the VCUG, or the voiding cystourethrogram, is the best way to make a diagnosis and to be able to assign a grade to the reflux. And in doing so, we can get other information that's very helpful to us in determining how we are going to manage this problem when that diagnosis is made.
Well, great, thank you. All right, so now as we imagine the journey that caregivers have, so a caregiver has either had this study ordered by their primary care pediatrician, or you've ordered this study on a patient, and the study's completed, and now they're back at your office to review the results. How does that conversation go?
When the child is coming to my office with the diagnosis of reflux, either because their primary care doctor or the hospital made that diagnosis, or I suspected it and ordered studies that were done to establish that diagnosis, the first thing that I explain to parents is that urinary tract infections are not normal in children. They're not normal in anyone. And when they are associated with a fever, that is a kidney infection. When we make the diagnosis of reflux, that establishes why they developed a kidney infection, because children who have reflux have a greater chance of having infected urine in their bladder. And it's not the reflux that causes the infection, but it's the infected urine getting up to the kidney that causes the kidney infection. And the reflux is the mechanism by which that infected urine gets to the kidney. So the parents and I have a conversation about what that means for their child. Children who have this diagnosis are going to have repeat infections unless something is done. And so our goal is focused on preventing that from happening. We want to protect the kidneys, because each time that the kidney gets infected, there is a bit of damage that's done to the kidneys, and the kidneys can get scarred and damaged, and we want to avoid that. And so the way that we avoid that is either by managing the problem or fixing the problem. Now, fixing the problem, I'll get to in a bit, but most children that we see who come into our office have this problem managed, and managing the problem means preventing further infections. The best way to do that is to keep the child on a small amount of an antibiotic every day to reduce the risk of infection. It doesn't eliminate an infection, but it significantly reduces the risk. And in children who are after the age of toilet training, it would also involve making sure that their bathroom habits are appropriate, that they are using the bathroom to urinate on a regular basis and not holding urine for long periods of time, and making sure that we manage other issues like constipation, which will have an effect on bladder emptying. And so by managing this problem, we can protect the kidneys and try to ensure that we keep the children from getting recurrent infections. Now, why do we do that? We do that because many children will actually not require intervention. They won't require surgery or some other procedure like deflux to correct reflux, because they will actually grow out of this problem as they get older. And whether they are going to grow out of this or not is something that we try to determine based on a number of factors, which include the grade of the reflux. And it also is dependent on the age of the child and some other factors, which we call the VUR index, or the vesicoureteral reflux index, that was developed in my practice by my associate, Dr. Andrew Kirsch. And this is a validated study, or a validated measure that helps us to give the parents an indication whether or not their child is likely to grow out of the reflux or not. And so initially, the majority of the children that we see in our practice who are young children, babies, young children, we will manage their reflux and give them an opportunity to grow out of this. And that usually means watching them for about a year and then having them return back to the office after repeating a VCUG and getting some imaging study of their kidneys, usually an ultrasound. And if the reflux is improving or resolved, then if it's resolved, we're done. We don't need to do anything else. If it's improving, then we would we encourage the parents to continue doing what they're doing, and we would give this more time. If it is no better, and very seldom is it worse. If it's worse, then we have to think about some other problems. But if it's not improving, then at that point, again, depending on the age of the child, we may go ahead and start the conversation about intervention to try to correct the reflux. So how do we do that? Well, we talk about the three major ways of correcting reflux. And that, of course, is there's a fourth approach, which would be to stop antibiotics altogether, which we might do in an older child with very minimal reflux, in whom we've corrected some bathroom abnormalities. And if they have recurrent infections, current episodes of kidney infections, then we have no choice but to intervene. But for the children that don't fall into that group, and that's a very small group, we can either approach this problem with open bladder surgery, or open surgery to reimplant the ureters into the bladder, whether that involves either opening the bladder to do that or doing it on the outside of the bladder. Those are two acceptable means of doing this. A second way, which is gaining popularity, is the robotic approach to reimplanting the ureters into the bladder. And then finally, the way that we in Atlanta have approached this problem is our initial procedure of choice, which is endoscopic correction using Deflux, which involves introducing the Deflux material under the ureter and essentially putting the Deflux pellet bleb that we introduce through a needle under the ureter to bulk up that space and prevent urine from traveling back up to the kidneys. And done properly, that is a very effective and reliable way of fixing reflux in the majority of children.
Well, Hal, that's a thorough summary of all the options that parents and caregivers will face when they come to see a pediatric urologist. And on our next episode, we'll delve in deeper to exactly what is a pediatric urologist and the distinction that your specialty brings into treating these children. So we invite you back and our audience members to join us on the Deflux for VUR YouTube channel on our next episode. Thank you.